Hi everyone, my name's Kev Tang and I'm one of the doctors in South Yorkshire in the UK. Welcome to the next webinar in this Mind the Bleeps radiology series, which aims to cover all the imaging modalities that doctors and healthcare professionals will come across in the hospital. I'm hoping that we'll have seen some of you before. This is the last webinar in this radiology series. Over the last 3 months, we've so far covered pretty much all the plain films that junior doctors will see in the hospital, as well as covering CT head, abdomen and pelvis, which Henry took us through last week. So today we'll be continuing with the CT section of the series. So Dr. Dexter Valencia will take us through a structured approach to CT chest, which I'm sure most of you will agree are pretty difficult to interpret if you've not had any formal training before. So Dexter's going to go through the anatomy, a logical approach to interpreting CT chests, and we'll discuss some cases with us. After the session, please don't forget to fill in the feedback forms, because completing that is how you'll get your certificate of attendance. And if you've missed any of the sessions in the past, then they're all available to watch for free on the Mind the Bleep website or on the Mind the Bleep YouTube channel. So we'll just go straight into it. So Dexter, I'll hand over to you.
Thank you very much, Kev. Hello everyone, my name's Dexter. I'm a 5th year interventional radiology registrar. I work in Addenbrooke's Hospital in Cambridge in the UK, and I've been asked by Kev to give a talk on CT chest. And as he mentioned, it's a very complex topic, even for radiologists, so I'll do my best to try and teach you some normal anatomy, but I'll go through several cases of common pathologies that you might see throughout your medical training, as well as your careers as doctors. So the whole idea of this talk is for you to gain some confidence with CT chest studies. What I'll be aiming to do is to ensure that you gain some experience in knowing what normal chest anatomy looks like and seeing some signs of common pathology. So the whole idea of this is not to make you expert radiologists looking at chest by the end of this, but to learn what the basics are of how to interpret what is normal, what interprets some of the abnormalities that you might see. It gives you a chance to ask me lots of questions as we go throughout, so please use the chat function on Medal to ask any questions. There are no silly or stupid questions. I'm happy to answer and explain everything as we go along. And hopefully each of you will leave this talk feeling like you've learned something new, even if it's just one thing related to the CT chest. That's still an achievement, and as long as you've picked up something, I'd be very happy. So this session is likely to be at least an hour, probably going on to about, about 9:30, so about an hour and a half, but it could go beyond, but it's going to be recorded. So if you need to leave or if you've got other commitments, that's fine. You can always catch up, and please do ask questions whilst you're here or put it in the chat function. So Kev's asked to give me this talk, and we've got a wide variety of experience within our audience. So we might have people with very little experience of CT chest, might have some really good experts. So you might be someone thinking, I've never looked at a CT chest before. So you may never have seen any imaging whatsoever, and you're a real novice and rookie to all of this, but hopefully we'll be covering some basic anatomy for you so that you can identify them on the CT study and see a bunch of abnormalities and say to some people, at least you've seen some. For some of you, you may have seen some CT studies, either looking online during studying or in any of your hospital attachments or your work placements, and you can see a few things like you can spot a big PE, you can see some infective consolidation, so you have some experience within the field of radiology. Maybe for you, you want to sharpen up in terms of your language, the terms, and maybe some of the signs that the radiologists use to describe what they're seeing, and also to see more pathology on top of whatever you've already studied or seen in hospital. And there may be some of you which are really good experts in what you're seeing with your eyes. So you might be thinking, this guy better be teaching me something good or I'm leaving the session. So the sharks of you in the audience. So for you, if you've got some experience, this is an opportunity to consolidate and add to any of your existing knowledge and get an insight into really what a radiologist is thinking when they're looking at imaging. And it's also your chance to question or grill me on anything related to radiology, and I'll do my best to answer it. So this session, because it's going to be quite long, I've packed it full of lots of common acute abnormalities that will be useful for you. I can't teach you all of chest radiology because that will take forever, but I've chosen a select few cases which I think are good in terms of interpreting signs and things that will be important and common that you'd see on your daily work. So for any of you that have attended the previous studies, there may have been chat about how we interpret the grayscale of a CT scan. So as you know, CT scans are multiple X-ray images that are put together, and it's based on a grayscale, so black, grey and white. And we use something called the Hounsfield scale, and it ranges from -1,000 to above a +1,000, and it goes from air, which is very dark and black, up to bone and things which are beyond that, things like metal, which can be really bright, going to 1,000 beyond. And the reference, if you have to remember, is 0, which relates to normal water. And then there are a few things around that which have certain Hounsfield units. So if we take fat, for example, here, just under the skin, if ever you've done surgery or if you've seen a cut, you can know that there's some yellow fat under here. And normally when we do a CT scan, that will come up to about -100 or less than 0, which is water. You can see that this is a CT slice through the chest. We've got the heart here. We've got the descending aorta here. We've got the right lung and the left lung. So whenever you look at a CT scan, this is going to be the right side. This is going to be the left side. Let's just have a look. Yeah. And if we think about fat being here, all these structures which are a little bit brighter, which are lighter in grey color, these are going to be the muscles. So these are the paraspinal muscles, because this is part of the thoracic spine. This is the left scapula, the right scapula, and these are all muscles. As we come sort of closer within to the mediastinum and this heart here, we've got our normal structures. So if we think this very thick layer here is the left ventricular muscle, and as we can see, if we were to measure this, it would be soft tissue, so 30 or 45. So if this is the left ventricle, we know that posteriorly we have something which is called the left atrium. We have the right atrium, which is in front of it, more anterior, and even more anterior next to the left ventricle is the right ventricle here. In this case, we've given this patient some intravenous contrast, so they've got a cannula. We've given them some dye, which is usually iodine-based, that runs through the bodies and it fills up the vessels and it goes into the tissues and it enhances them. And as you can see, it's filled up the structures which we mentioned before, the left atrium, the left ventricle, a little bit within the right chamber, so the right atrium, the right ventricle, and it's gone down the descending aorta. If you notice, if we go into this end of the scale, we've got cortical bone. If we take the scapula, you can see it's a lot brighter than the muscles next to it. It's very dense, and that's why it's such a high value on the Hounsfield scale. So that's just giving you a brief overview of how we interpret things on a grayscale on the Hounsfield units. We're thinking about giving contrast. In this case, it's in the vessels. It's been given intravenously, and I'll talk about windowing in a moment. So this is a CT slice of someone's chest with IV contrast. If we come a bit lower, we can see that we can look underneath the diaphragm and look at some of the other organs. So you often can see things such as the top of the right and left kidneys. You can start to see a little bit of this structure, which is the right lobe of the liver. This structure here, which looks a bit blurry, we're starting to skim the gallbladder. And these things, which look quite circular and black, if you imagine outside the patient, there's nothing there, so that's going to be gas. So this is a structure within the abdomen, which has pockets of gas within them. These are going to be bits of large bowel. So actually within this large bowel, these circles of gas are probably small diverticular. And whenever we look at these CT images on this setting, so if you imagine the lungs, you can't really see much detail, but you can see all the detail of the soft tissue, the heart, the kidneys, the liver. This is what we'd call a soft tissue window. So it's just the setting that you've put on your screen related to the images to help adjust your eyes to see certain structures. We can do that with the lungs. So this is what we would call a lung window. Notice how a lot of the bones, the muscles, the fat, you can't really see it. The imaging has been changed so that you can focus more on the lung tissue itself. So you can see all these white lines, which are vessels filled with contrast. filling in the lungs. Here we can start to see these gas-filled structures, this on the right and this on the left. These are going to be air-filled structures which are central. So we know from our anatomy this is probably going to be the right main bronchus and the left main bronchus. So in terms of using this Hounsfield scale, whenever we start to talk about CT scans, let's keep it simple. If something looks dark, you'll normally say it's low attenuation, hypoattenuating, or low density. Things like air we saw was quite dark and black. Things like fat, they're quite dark, so they're low density. If something looks bright or white, we start to talk about things like high attenuation, hyperattenuating, or high density, things like bone. Windowing, all that means is that you're changing the settings of your image so you can adjust the brightness and contrast to your eye, so you can start to interrogate and analyze certain bits. It's quite difficult to interpret, say, the lungs on a soft tissue window like we saw before. So it's just adjusting things so your eyes can analyze it better. So normal CT chest. So as a radiologist, I have to look at a lot of images and I have to make sure that I don't miss anything. I have to look at every little structure in my own systematic way. For you that are just starting out looking at CT chest, you might not need to look at every little detail. You want to look at lots of abnormalities within the lungs, maybe in the heart and the mediastinum, but you're not going to be looking for tiny, minute details. But this is just how I would look for it. So we'll go through some cases so you can see them. So we'll start from this case. So this is radiopedia.org. It's a very good resource if you want to just look for any abnormality. So we're going to start with a CT scan without any contrast. So what the radiographer who performs the CT scan will do, they'll start by doing some CT scanning, and this is what we call the planning scan or the topogram. This just helps plan how much of the patient they're going to scan. And it looks pretty much like a chest x-ray. So this is just helping to plan. Here we have axial, so slicing horizontally through the patient. These are axial non-contrast CT scan slices. So here I'm just scanning through, and like we said before, you can see all the muscles and this fat, and you can see the mediastinum, and this is the soft tissue window. In contrast to what we said before, this is the lung window where everything outside of the lungs looks quite white and bright, because this setting wants you to focus on looking at the lungs itself. So if we just go through some normal anatomy, we can start, say, with an ABC system, so airway. So this central round structure has cartilage to keep it nice and round. This is what we call the trachea from your anatomy, and we know that as we come down, it splits in two. So we've got the right main bronchus and the left main bronchus, and this point where it splits, as you know, is called the carina. In terms of clinical relevance, we know that the right main bronchus is shorter and more vertical, so whenever anyone swallows anything, it normally goes down this structure here. And as it branches out, it goes into obviously the right and the left. And to keep it simple, we know that the right lung has 3 lobes, the upper, the middle, and the lower, and the left has an upper and a lower. So those are the lungs. If we are doing an ABCD approach, so if we go A, that's airways, B is breathing, so looking at the lungs itself. So we know that we've got these black filled structures with these vessels. These are the different lungs. These lines that you can see here, as we scroll through, you can see that they both move forward. So as we scroll and go up towards the apex, you can see they're moving back and back and back. These are the oblique fissures that you normally see in the lungs. And if you know your anatomy, on the right side, there's this subtle line here, which runs in front of this, and that's the horizontal fissure, which you only have on the right side, but not on the left side. So that's some of the basics of airways and breathing. And what about surrounding the lungs? So normally, in like this case, in a normal lung, there would be a pleural space, and in normal patients, there'll be, say, a teeny bit of fluid for lubrication, but you shouldn't be able to see it. So here we can't actually see the pleural space. We assume it's between where this lung ends and where these ribs are starting, so that chest wall. So that's where the pleural space would be. It runs all the way around these areas here. So now we've done airway, breathing, we can then move on to structures within the mediastinum. So this is what the mediastinum, things such as the pericardium, the heart, the aorta, the pulmonary veins. These are quite difficult to see with any contrast. They all look very similar and it's hard to tell them apart. So it's useful to go on to a contrast study, as we can see here. So we've given the patient some contrast and we can see all the chambers and all the vessels quite nicely. So we'll go through some normal anatomy and I'll go through it through the journey of how the blood flows and where the contrast is going. So this patient has on their left arm, they probably have a cannula. We've injected some contrast and we can see that because contrast is really bright, it looks a lot brighter, similar to bone, and it's passing into this vessel, which is a vein. It's outside the rib cage, so this is going to be the left axillary vein. And we know that once the axillary vein passes the first rib, so we can count that. So if we say that's the first rib, we follow that round, keep following that round. About here is where the left subclavian vein is going to enter. And the next step is going to be the left brachiocephalic vein, and it joins, this is the right brachiocephalic vein. It hasn't got any contrast because it's come from the right side of the body. As it joins here, we've got the superior vena cava, or SVC. That's going to come down into what we call the right atrium. We know that the right atrium then goes into the right ventricle through something called the tricuspid valve, which you can't see because it's very thin and it's obviously moving and beating. After the right ventricle, which is this structure here, if you just follow the white bits where the contrasts are, it goes through the pulmonary valve, which you can't often see, and then it goes into the pulmonary arteries. So this structure here is the main pulmonary artery, and it then goes into the right and the left, and then like the airways and the bronchioles, or the bronchi, they will go into their different lobes. So right upper, right middle, right lower, left upper, left lower. Once the blood has been oxygenated, it will then return to the heart through the pulmonary veins. So for example, if we follow this structure here, it will be returning from here, going through this structure and then into this more posterior cardiac chamber, which is the left atrium. And this left atrium will tend to have 4 pulmonary veins draining from the lungs. So we can see there's 1, there's 2, and as we go a bit higher, there's another one coming up here, and there's another one here. So this is the left atrium. We know if we go through our normal anatomy, it then goes into the left ventricle. We know this is the left ventricle because it's got a nice big thick muscle around it. That's to help push that blood all the way around the body. And then from there, we've got this is going to be an aortic valve, which you can sometimes see as these sort of lines here, but it's very difficult to visualize. And then we start to go into our ascending aorta. As you come up, you'll have your normal aortic arch, and you'll normally have several branches coming off. Normal anatomy would be 3 main branches. The branches would be, the first one would be going towards the right arm and the right side of the neck. So that's the right brachiocephalic artery. The next one would be the left common carotid artery. And the last one should be the left subclavian. In this case, it looks like there's 4, which is what we call a variant anatomy, which is normal and can be in the population, which you can see. So here we have the brachiocephalic, the left common carotid. This is probably a left vertebral. This normally comes off a bit further from the subclavian, and here's the subclavian. So it's just a variant. If we come down the aortic arch, you now have the descending aorta, which is going towards the abdomen. If we think there's a gas and fluid filled structure here, we know it's gas because there's gas on the outside, gas here. You normally have a gastric bubble. This is the stomach. If we trace that back up, we can see a little bit of gas here. That's going to be the esophagus. So it's quite difficult to see on this, but there is an esophagus which runs all the way towards the neck. So these bits of gas are normal here. That's just the normal esophagus. So we've covered the mediastinum. We've covered the lungs, the airways. What else can we cover? In young patients here, you can see there's a little bit of a triangle, and and it's similar attenuation or density to muscle. This is probably just a normal thymus or thymic remnant, which you can see in young patients. As we come a bit lower, we can sometimes on a chest CT, you often get the upper abdominal organs. So here we have the kidneys, we've got a bit of the aorta and its branches, we've got our right kidney, we've got a bit of the liver coming into play, and we've got the spleen over here. It's quite difficult to see the organs just because of where the contrast is here, but those are some of the things you'll be seeing. And obviously you've got all the different bones that you can see. You've got the thoracic spine, you've got your scapula, you've got your clavicles. This is probably a bit more familiar because it's like X-ray anatomy. So those are some of the normal things that you would see. Sorry, I'm just looking at my phone just to make sure if you want to ask any questions, you can. So that's just one way to look at anatomy. If you have some time, you can use an ABCD approach, looking at as we did. For me, my approach would be to look at all these things. So these are my sort of checklists that I look at to make sure I don't miss anything. We won't go into too much detail because we want you to see some normal and abnormal CT scans, and I think this might take a bit too long. So our first abnormality would be talking about pulmonary thromboembolism, or PEs. So this is quite a common diagnosis, and it's a scan that we do a lot of CT chest scans for. The thrombus normally originates from pelvic and lower limb veins, and then they will start there, and then they will move and migrate and embolize into the pulmonary arteries. In this talk, we're going to be talking about thrombotic emboli, but you can have other things going into the lungs. Things such as gas, fat. Fat might be from long bone fractures, so orthopedic patients who have had surgery or trauma to the lower limbs or long bones, they can embolize the fat from the bone marrow into the lungs. You can have tumors like kidney tumors going into the lungs. You can have foreign materials and amniotic fluid. The main talk of today will be of thrombotic PEs. So whenever you request a CTPA, I'll get a call from a doctor and I'll ask them, what are you worried about? They say, well, this patient's come out with sudden right-sided chest pain, they're short of breath, I'm worried about PE. So I want to do a CTPA, please. I'm okay. So I say, that's fine. I tend to look at a chest radiograph before. It's a useful test to get a chest X-ray before you do a CT, even if you think that's PE is the most likely diagnosis. Here in the UK, it's are sort of nice guidelines to get a chest X-ray first. It can reveal some other diagnoses which you may not be suspecting, things like a pneumothorax, an infective consolidation, a big pleural effusion. They could have a big cancer or metastasis. It just gives a bit more information before they scan the patient. So it is a useful test to make sure we do, and it's quite easy to get before getting a CT scan. So I would recommend, if you can, doing a chest radiograph first. Radiograph or X-ray. A D-dimer, it can be useful. A lot of patients come to hospital with a lot of other problems, so it may not be useful in a patient who has infection because it's probably going to be raised. But if you've got a young patient that you don't want to really scan, and it's maybe the last differential that you just want to rule out before sending them away, if it's a negative D-dimer, they're unlikely to have a PE, so it can be a useful test at times in certain patients. And when you request a CTPA, just make sure the patient has good IV access, I'll come on to why, and make sure you're happy to give contrast with their creatinine level. Make sure they haven't got a lot of kidney failure before we start giving them contrast. So how do we actually spot a PE? Well, we have to do a CTPA or CT Pulmonary Angiogram. And all that means is that you give the patient intravenous contrast medium and you get lots of it within the pulmonary arteries, giving yourself the best chance to have a look at where the PEs are within them. And you need good IV access, so a lot of places will ask you to have a good large bore cannula, usually at least a pink cannula, so that we can achieve that. And what we look for as radiologists is that when we do the scan, for it to be a diagnostic CTPA, we draw a special circle called a region of interest to measure the Hounsfield units. And if it's above 250 Hounsfield units, that's a diagnostic CTPA, and it means that we have a good chance of spotting it. Anything less than that, your sensitivity of picking up a PE is very low, so you might miss some small PEs, which can be quite important for the patient. So what does acute PE look like? So if we go back to our last example, we can see that, let's go through some normal anatomy. So like we said, this is on a soft tissue window. We can't really see the lungs, but we can see all the vessels nicely. We can see that if we look at the black areas, this is probably going to be the right main bronchus, the left main bronchus. This is probably the esophagus behind, a bit of spine. Can't really see the lungs, but we know the right lung is here, the left lung is here. This bright circle or oval here, that's where we've given the intravenous contrast medium. So this is the superior vena cava. We can't see the rest of the heart, but what we can see is we can see this main pulmonary artery is where we've taken the measurement. We've got the right pulmonary artery and the left pulmonary artery. And here we can see in the left pulmonary artery, there's something not quite normal from what we saw on the normal one. So it looks like there's this low attenuation, hypodense abnormality, which we'll get into that. So that is a PE. But what does it look like? How do we describe it? So it's a low attenuation or dark filling defect surrounded by contrast medium. So here we can see on our first example, this is the right pulmonary artery, and that bright oval in front of it is the superior vena cava or SVC. And within here, we can see this low attenuation or dark filling defect, which looks like a line or a sausage. So we can say it's a linear defect, which just means line. And that is a PE within the right pulmonary artery. And we talk about, as radiologists, this polo mint sign. So for any of you that have ever had a polo mint, it's a mint sweet. We know that it's got a white circle and it's hollow in the middle. So that's what it'll look like. You can see this is a pulmonary artery looking in the axial plane. So looking right into the vessel. We can see that there's a low attenuation or dark circle within the middle of it. And that's the thrombus within the middle of the pulmonary artery. So that polo mint sign. As you get further and further deeper into the branches of the pulmonary arteries, it's not always possible to get this really pretty pulmonary artery polo mint sign. What you might see is just dark vessels. So I've highlighted here, the white asterisks are pulmonary arteries, and the red asterisk is a pulmonary artery which looks a bit darker compared to all the other ones. And that's because there's thrombus within that artery, and it means contrast isn't there, and that's why it looks darker. Some of you may be wondering, there's so many vessels, Dexter, there, I can't make out what these are. Why aren't these pulmonary arteries? Why aren't these PEs? Well, these, remember, you have pulmonary arteries and pulmonary veins. You get pulmonary emboli within the arteries, not the veins. So these orange bits relate to pulmonary veins where the blood is returning back to the heart. So this isn't a location where you get PEs, it's the arteries, not the veins. So if ever you go to the hospital and you want to make sure that you can try and look at a CT study and see if you can see a PE, you want to make sure that your window or your brightness and contrast is set up correctly. So normally there may be a button to help you get to there, but sometimes you might have to do it by clicking and moving the mouse around, and that's what we call manual windowing. So if we take this example, again, this is a CTPA, we'll measure here, it's more than 250 Hounsfield units, it's diagnostic. This is the main pulmonary artery. Again, this is the right, this is the left, right main bronchus, left main bronchus. Here we have the really bright circle here, which is the SVC. Here we have the ascending aorta. Here we have the descending aorta, and we have a bit of the spine here. If we go back to this main pulmonary artery, it's really bright. All you can really see here is white. You can't really see within the vessel. So if you imagine if it's too bright, you might not be able to see what's inside the vessel. So what you want to do whenever you're looking at a CTPA is to window it or adjust the brightness and contrast so that you can see a little bit of graininess, a bit of gray within the vessel, so you can see within the vessel, so you give yourself the best chance of finding this PE. So here we have this large PE going across the left pulmonary artery and the right, and it's joined together. And that's what we call a saddle pulmonary embolus. It's related to a saddle that you'd see on a horse. It goes over the back. That's what this is. So again, this is a CTPA. We've got lots of contrast within the main pulmonary artery, and we can see this linear filling defect, which is in the right pulmonary artery, the left pulmonary artery, going across there. So this is what we call a saddle pulmonary embolus. This is usually quite bad. The patient tends to be quite unwell, requiring quite a bit of oxygen. So saddle pulmonary embolus. Some of you that work in the hospital or read radiology reports, you might see radiologists reporting things like segmental and subsegmental level. And I didn't know what this was when I was training as a medical student. When I was a junior doctor, I only knew what a pulmonary embolus was. But what's the segmental and subsegmental level pulmonary embolus? You might see some of this when you go to the hospitals. So if you just imagine in anatomy, as you have more and more divisions going deeper into each of the lungs and lobes, it gets divided into all these different segments. And if we keep it simple, similar to the airways, the vessels do the same thing. So let's take the trachea. If we start with the trachea, and if we have this as well, if you imagine we have the trachea, it divides and it goes into the right and the left. So let's take the left route. So say if we go down the left main bronchus, as we go down the left main bronchus, it's going to divide again, going into the upper lobe and the lower lobe. So let's take the lower lobe. We're going to go down here. As we get to the lower lobe, there's going to be even more divisions. And within each lobe, there's a certain number of divisions, or what we call segments. So in the left lower lobe, we have 5 segments. You don't have to know what these are. If you're a radiologist, you probably do, but at whatever stage you are, it's quite a lot of detail. But say if we go to the left lower lobe, we'll take the superior segment, and that is a segment by itself. And if we go any further within and deeper into the smaller vessels, those are going to be subsegments, so subsegmental level. So all this means is that as you get into these segments that you can see in these diagrams, those are segments, and as you go beyond those, they're subsegmental. So similar to the vessels, as you go deeper into the lobes and divide, that's all they mean. So those are segmental and subsegmental Ps. It's just to do with what level of division they are. An important thing when it comes to pulmonary embolism is talking about heart strain. So whenever you see a PE, you might see a radiologist report about right ventricular strain or right heart strain. It's quite an important diagnosis, and it has some implications of how you might manage the patient. So let's look at some normal anatomy. So this is an axial CT slice of the chest in a patient. Through the heart, we can see that it's quite bright within this left ventricle. So we've given this patient contrast. Here we have the right ventricle, and in between we have this thick wall, which is the interventricular septum, and that's a normal structure there. So in a normal patient, the interventricular septum should be curved, and it should be bowing and pointing towards the right side of the patient. Remember, this is the right side, this is the left side, this is the left ventricle, this is the right ventricle. So remember, this left side has a higher pressure system, has a higher blood pressure, so it's going to be bulging towards the lower pressure system side. So this is what it looks like in normal anatomy. It's not massively curved, but we can sort of draw this curve going towards the right. Whenever you have a big PE, that puts a lot of strain on the right side of the heart. And what that means is that this interventricular septum will start to straighten, and that's bad news. And sometimes it will even bow towards the left, and that's really abnormal. We explain that the left side should be a higher pressure system. So we're putting a lot of strain on the right side of the heart. We can see if we measure the inside of the left ventricle, it's quite small. If we take the same measurement on the right, we can see that the right side is a lot bigger than the left. That's also a sign of right ventricular strain. So this abnormal bowing towards the left, the right ventricle being a lot bigger. This is bad. The patient's likely to be unwell, and we'd normally recommend that the patient has an echocardiogram to confirm, and this might dictate if the patient needs further strategies such as thrombolysis to try and treat the PEs, or something more than just normal anticoagulation to treat the PE. If we talk about right ventricular strain, there might be something called pulmonary hypertension or raised right-sided pressures. And how we can see that on a CT is by looking at the main pulmonary artery. Normally anything less than 29 millimeters is normal, But if it's above 29 millimeters, we get suspicious that it's abnormally elevated and increased. So this one is 35 millimeters, which is really big. And you can even see the saddle embolus, or part of it, going into the left pulmonary artery here. A patient may have pre-existing disease, which might mean they have raised pulmonary hypertension already. So whenever I see a PE and it looks like a big saddle PE and they have a raised main pulmonary artery and it's more than 29, I probably think it's related to the PE, but they could have really bad lung disease. They could have pre-existing medical conditions that mean they have pulmonary hypertension. This is just an example of a really long list of causes for pulmonary hypertension. I'm not expecting you to know this, but it's just to be aware that, PE is not the only thing that can cause it. Some of you may have heard of wedge infarcts. So if you imagine we're talking about pulmonary arteries, if you block any artery in the body, wherever the blood is going to, it's not going to be supplying it. It will be impaired, and that area of tissue will become ischemic and die and necrose. And what does that mean? So a wedge infarct, as it suggests, it's wedge shaped, like we can see here. It's got this triangle appearance. It's in the periphery, so it's very far into the tissue, all the way out to the lung edge. That's where you find them. And as well as its shape, it looks like this one is quite hazy. This is what we call a ground glass opacity. I've put a star next to ground glass opacity because I will explain what that technically means to give a clear explanation. You might get a bit of consolidation in a wedge shape. And what it ultimately relates to is abnormal vessels that have pulmonary emboli. So if we were to trace this CT back to the vessel, to this area, we would probably find a PE. This is just another area where we can see this is a CT slice in the lung window. Notice how everything is white outside of the lungs, but you can see all the sort of beautiful detail of all the vessels within the lungs. Here within the right side of the patient, so this is the right lower lobe, we can start to see that this bit is liver, so we're quite low in the lung base. We can see posteriorly there's this triangular wedge shape. There's an increased attenuation or high attenuation wedge shaped area, and this is consistent with an infarct. Other things that you can see with PEs, so here we have two CT slices. Over here we have the lung window. Here we have this soft tissue window. Some of you may have spotted on the soft tissue window, there are some filling defects here. These are the polo mint sign that you can see. So if I so these are the acute pulmonary emboli. We can see that they're filling the vessels. And what you can see here is there's an abnormality within the posterior part of the left lung. You can sort of see it on the lung window, but it's probably a bit easier here. And what this is there's fluid within the pleural space. And any of you that have seen a chest x-ray with a pleural effusion, you know you get that rounded meniscus sign. And this is exactly what happens as well. You get this meniscus sign. And if we were to measure this on our Hounsfield units, it would probably be close to water, so close to 0. So this is a pleural effusion. It's quite a small one on the left side. And there's something called atelectasis. So anyone who's ever done a surgical job, after your patient has surgery, they might be in a bit of pain. They're not taking big breaths in. What happens is far into the lung parenchyma, quite distally near the edges, there's bits of alveoli that aren't quite expanding, and they sort of fold in on each other and they haven't quite expanded. So it's just distal collapse. And what that shows up as are these sort of lines or linear opacities. And this is typical for what we call atelectasis. I see this in most of the CT scans, so it's quite a common finding. But if you imagine a patient has a lot of pain with the PE, they might not be taking a lot of deep breaths. So that stops air from getting to these areas. So that's just a bit of atelectasis in some PEs with a small effusion as well. Also, you can see this heart, this right ventricle is looking quite big. This septum is looking like it's starting to straighten. I'd be starting to worry about right heart strain in this patient. Another thing that can happen, so if we go through normal anatomy, so here we have some CT slices. This is a coronal image after we've given some patients with some contrast. This is an axial image. And again, this is another axial image, but looking at the liver. So let's explain these. So we've given contrast for the right arm. It's gone through the right axillary vein, right subclavian vein, the brachiocephalic, it's going to join the left brachiocephalic to form the superior vena cava, and this is the right atrium. And the reason why I'm showing you this anatomy is because tricuspid regurgitation relates to the tricuspid valve, which you can't really see, but we know that it's going to be at this junction here between the right atrium and the right ventricle. And for some of you may have noticed, this right atrium looks like it's quite big compared to the ventricles, and it normally shouldn't be like that. And the reason is this tricuspid valve is under pressure, it's not working properly, so a lot of the contrast is actually going backwards from the ventricle into the atrium. Oops, sorry. So that's causing enlargement, and it can be so bad that it starts to go down into the inferior vena cava. Remember, this is superior, this is inferior. And if you are familiar with some liver anatomy, we know that the inferior vena cava connects to the hepatic veins, which we normally have 3. So here we have the left hepatic vein, the middle, and the right. So if contrast is going from the heart into the liver, then you can see that this patient has tricuspid regurgitation, which can be seen in PEs. I'll give a small talk. So in terms of PEs, we've covered a lot about acute PEs. Just a slide on what chronic PEs looks like. So there may be a patient who presents and you might do a CT scan, and you may see a filling defect in some of the pulmonary arteries, and it might not look like what I've shown you in these last few slides. It might be that it's more to one side. So this is just one tool that radiologists will use when analyzing these scans to determine the age of this PE. So here in acute PE, it will be central with this nice polo mint sign. In a chronic PE, it tends to be what we call eccentric, to the side, non-central. So that's one way to differ between the two. I'll just go through some examples. Please feel free to ask any questions on the chat function. I can't see any yet, but Kev, if you see any, please do let me know. So here is a CTPA. We know that because we can see that this is quite bright. In my normal practice, I would draw a region of interest to have a look at the Hounsfield units, but this looks like it's going to be way above 250, so I think it's going to be diagnostic. Let's go through our normal anatomy of how the blood flows. So this is the SVC. It's very bright because it's got a lot of the contrast in it. We're coming to what we know as our right atrium. It's our right ventricle. It's looking a bit big, so it's a bit worrying. We can see that this interventricular septum is straightened. You could argue maybe it's starting to curve towards the left again. Are we going to be seeing some right heart strain? And if we come to our main pulmonary artery, as we scan through the right, there's this linear filling defect here, which I'm a bit concerned about. That looks a bit abnormal. And we can see as we go into the left, we can see that there's this clear linear filling defect, which is a thrombus or pulmonary embolus. And we can see it's starting to go into all these small vessels into the left side of the lung. So as we scroll down towards the base of the left lung, in the left lower lobe, here's a pulmonary embolus. In the right lower lobe, we can start to see all these low attenuation areas going into, so here we can start to get some of those polo mint signs we were talking about before. So here, so that is abnormal. So this patient has extensive bilateral pulmonary emboli, and we can see some evidence of right heart strain, as we can see, because the right ventricle is massive compared to the left. Can we see any tricuspid regurgitation? Well, the liver looks pretty dark. I can't see any contrast within there, so it doesn't look like they have tricuspid regurgitation, just big PEs. We'll go through to another one. Again, this is just demonstrating that Radiopedia is a really good resource. So here we have another CTPA, and as you can see, this is what I was talking about in terms of windowing. So here we can get a bit of graininess here. It's not as bright as the other one, but it just helps you see inside the vessel. So there's no saddle P that I can see here. There's nothing going into the left, so that's good so far. Let's go back to our normal anatomy. So here we can see lots of contrast in this SVC. And this brings me onto my next point. If you look very closely at this SVC, you can see these black lines sort of radiating around here and some white lines. This is artifact. So this is what happens when you give a lot of contrast. Artifact is just something that you see on the image, which is produced falsely because of the way the X-ray is taken, but it doesn't really represent what's happening in the patient. So it's essentially, it looks abnormal, but it's because of how we've taken the picture, but it doesn't represent what's happening in the patient. So it's not a true thing that's happening. And this can affect some of your imaging. So this is something we call streak artifact, when you have really dense contrast here, and that can sometimes mess around with your vessels nearby when you're trying to look at PEs. So if we keep scrolling, let's follow this main pulmonary artery. So as we keep coming down here, oh, we can see there's something going on here. So if we use something else for reference, so let's just scroll down, sorry. If you compare this pulmonary artery compared to this, you can see there's this filling defect here, almost like a polo. And as you keep scrolling, there's something not right around this area. I can't tell where it is because we're on the soft tissue window. We might have to get to the lung window actually. So if we go to that same area, so we can sort of see that was the vessel that was affected. There's this really abnormal area within the right lung. So this is actually the right lower lobe. This line that you can see here that I'm drawing out, that is the right oblique fissure, and we're starting to see some of the right middle lobe here. We can see that this area is really dense. It's really abnormal. It doesn't look like normal lung tissue. And what this is actually, because it's related to this pulmonary embolus that we saw before, this is actually a large pulmonary wedge infarct. So this area has been starved of the blood because of the PE, similar to these areas in the right middle lobe. So these are wedge infarcts. So that's an example of wedge infarcts. Like with all PEs, we want to analyze, is there any right heart strain? So this left ventricle actually looks a lot bigger than the right. This doesn't look like it's going towards the left. Some of you might say it's probably a bit straight. I don't think it is. I think it's sort of slightly curved. And also I would measure the pulmonary artery, make sure that this wasn't enlarged. Just checking for any questions. So none so far. Kev, please do tell me if there are some questions. So CTPA, there can be some problems. You might not get enough contrast, so it won't be diagnostic. Sometimes you might have a CT scan which is already done, and you want to check with the radiologist if there's a PE on there that they may have not looked at. They should have, but you can always ask them. And remember, as long as it's above 250, they can check. If it's less than that, it's difficult. There are artifacts. So motion artifact I didn't show you, but if you imagine the heart is beating quite a lot, that can affect some of the tissues next to the heart, specifically in the left side of the lung, and that might affect your interpretation. Same with that streak artifact from the dense contrast. And remember, you want to always trace the arteries, not the veins, and make sure that you can just go back to that main pulmonary artery, the left and right, and that can always help you trace where you're going. Okay, so tips: go over your anatomy, follow the arteries, not the veins, and window correctly, like I said before. So a little bit of graininess, make sure you can see through the vessel. For me as a radiologist, what I want to give to the clinician is there a PE, is there a right heart strain, and the other stuff I mentioned as well. So the location, do I think it's acute or chronic, and are there any other associated things? Also, if there's no PE, it's useful to let the clinician know, is there a rib fracture, is there infective consolidation, is there a pneumothorax, things like that, because it won't always be a PE. So aortus. So if I can't see any questions, so I was going to use this to take any questions. So please use the chat function to ask or message Kev, and he'll be able to signal to me, but I'll just keep going. So aortas, so one thing I want to cover is something called acute aortic syndromes. Most of you would have heard of acute dissection or aortic dissection, and that falls into the spectrum of acute aortic syndromes. And there's 3 diagnoses. Most of you know dissection, and that's the most common. It's a very important diagnosis, and there are 2 other ones which I'll briefly touch on because they can present in the same way. That's why they're all under this syndrome. So you have a patient that comes into your emergency department, they're a smoker, they're talking about this chest pain which is really severe, it's going towards their back, it feels like a tearing chest pain. You need to think that this patient might be having acute aortic syndrome. And how do we look at that? Before we go into any scanning, we need to understand what that is. So if you imagine Any artery in the body, like the aorta, has 3 layers. You've got this inner layer, which is the pink bit here, that's the intima. We have the middle muscular part, which is the media, represented by this red area here. And we have this outer layer, the externa, which is represented by the yellow part here. And essentially what an aortic dissection is that you have some sort of abnormality or tear or dissection within the intima, this pink layer, and that means that blood will go from where it normally is in the true lumen underneath the intima into a false lumen, and this tear creates this intimal flap with blood going onto here. So the false lumen fills with blood, and that's what's causing the problem, and that's what gives the pain, that sort of tearing through here. And why is it important? What are the causes? These are some of the causes here. Obviously this is recorded, so we can come back to this. You think of atherosclerosis, vascular paths, connective tissue disorders, things like Marfan's, Ehlers-Danlos, things like that. Those can predispose patients to be having these aortic dissections. And why is it important? What happens when this pathology occurs? If you imagine you have this tear, you fill the false lumen, what happens is that you will compromise areas of the body supplied by blood. So you get end organ damage or ischemia. So what happens is, say if you have a tear within the ascending aorta, that can rupture into your pericardium and prevent your heart from beating blood around the body. That's really bad. It could involve your aortic valve, so you get aortic regurgitation, so you're not getting enough blood around the body, which again, really bad. You can dissect and block off your coronary arteries, which will give you your classic acute coronary syndrome or myocardial infarction. Again, very bad. As we continue around our normal anatomy, just think about all the branches that come off the aorta. You've got branches which go to the upper limbs, so they might get a cold pulseless limb. You could have a stroke. You could block off blood supply to branches within the abdomen, so you'll get ischemic bowel or ischemic organs. And you can cause ischemia to the lower limbs, depending on how far this false lumen travels. So that's why it's really important. These patients can deteriorate and die if we don't pick this up. So some of you who have studied aortic dissection, you'll know about certain classifications. Here in the UK, we stick to the more simple classification, which is the Stanford classification. And that's simple because it's only type A and B. So if we ignore the other DeBakey classification for now, let's look at the Stanford classification. What this means is that type A involves the ascending aorta. So if you notice here, we have a dissection here. It's involving the ascending aorta, the arch, and it's going down into the abdomen. So that's the type A. This one's not as extensive, but it's involving the ascending aorta up to this branch, which is the brachiocephalic artery. And that is what we call a type A as well. Type B is anything past this structure here. So remember our branches: ascending aorta, brachiocephalic, left common carotid, left subclavian. Anything distal to the left subclavian, in this case, this dissection, is a type B. Here we have one going towards the diaphragm. This one is a type B going into there. Type A, type B, the important landmark is this left subclavian artery. Anything before that involving the ascending is going to be type A. Anything distal is type B. And I'll come on to why that's so important. So what are you worried about? I'm worried about chest pain radiating to the back. You're worried about aortic dissection. A chest x-ray can be normal in a dissection, and it won't change what happens to the patient if you're still suspecting. They're probably going to get a CT anyway. And if they're unwell, you should probably just get a CT scan as quickly as you can. You need good IV access. Creatinine, if the patient is likely to deteriorate and die soon, the kidneys are probably not going to be too much of a concern. You want to make sure this patient doesn't die immediately. So discuss with your radiologist, get IV access. And what we do is we'll do an unenhanced CT chest without contrast, and then we'll do a whole aorta with contrast, and I'll explain why. What does a section look like? So here we have a case, some axial images, sort of in a soft tissue window, but what we've done is we've adjusted it so that you can see the normal structures. So if we think from our CTPAs, this is the main pulmonary artery, which you can see in the left. And as I mentioned before, we've got the ascending aorta, descending aorta. Here's that SVC with a lot of the contrast in it. What you'll notice is there's an extra added line which we didn't have in any other previous studies, this vertical line going here and this other line here, and that's that intimal flap. This is an acute dissection. And for any of you that are just paying attention from the previous slide, this is involving the ascending and descending. So this will be a type A. As we come up towards the aortic arch, we can see that this line is the intimal flap here. So we have two lumens. We have the true and the false lumen. Sometimes it can be quite difficult to tell which ones are which. Normally what you have to do is trace, and I'll show you an example that I have soon. Normally the true lumen is the smaller one as you go further down. Here, as we go further down, you can see that we've got this intimal flap. We have got the false lumen, and we've got the true lumen here as well. It's going further down into the abdomen, further and further, all the way down into the pelvis. Here's another case. So here we can see that we've got the aorta starting here. We can see this abnormal line. And we can see that there's a difference in the contrast here. So it's quite bright, and this one is quite dark. And we can see that this dissection flap is extending up to the arch. And we can see that there are two different lumens. One is a bit darker than the other. And as we come down, like I said before, this brighter one is the true lumen, and this darker one is the false lumen. Oh, I've got a few questions in the chat. Let me just finish this and I'll answer any questions. As we come down, we can see that we've got two different densities here. This is the true lumen and the false lumen, and that's coming down to the abdomen. Okay, so I've got two good questions from Nicola White. So one is, why are normal pics not suitable in CT scans? So the issue with normal pics is that whenever we want to give a lot of contrast for the CTPAs, what happens is we connect them to a pump and we put a lot of pressure on this mechanical syringe. And what happens is if you blast a lot of contrast through a normal pic line, the end of the pic will actually explode and you can get bits flying off into the patient, which is really bad. So that's why we don't use them. A way around that is to have what we call a power pic. And what that is that's a strong enough pic line that will allow that. Sorry, a pic line is a peripherally inserted central catheter. So it's essentially like something which will go in the arm, and it's a long line which will go all the way in. The tip normally sits in the SVC, that structure that we were mentioning before. So that's the reason why we don't inject under normal pics, because if you inject really hard into a normal pic, you will damage it and explode it, and it can cause harm to the patient. So that's why the radiographers are really keen not to use it. And that's why if they want to know if you have a power pic. There are a lot of reports of subsegmental Ps which are not always treated. Are they less significant? So if we think from a perspective, if you have a large central P, that's really serious. As we get smaller and smaller into the vessels, if they're really peripheral, they might not be causing any symptoms. They may not be causing any oxygen requirement. As a radiologist, my job is just to say yes or no. There are PEs, there are not. So in some cases, I have seen subsegmental PEs not being treated by clinicians because they don't feel the risk benefit of anticoagulating the patient is there. So yes, there are subsegmental PEs which are not treated, but that's a decision made by the clinicians and the surgeons and the doctors, not by the radiologists. So we will report it. Are they less significant? That's for the doctor to decide. They probably aren't as significant as, say, a large PE saddle embolus with right heart strain, if that answers your question. So we're just going to go through a type A dissection. So remember, Stanford classification, we're talking about ascending aorta. So let's start with normal anatomy. We've got the left ventricle, we have the right ventricle, and as we follow up, we can see that there's contrast within the aorta, and we can see abnormal lines which weren't there before. So this is probably the true lumen. Here we have some low attenuation crescent, which is probably some thrombus. This is probably the true lumen, and this is probably false lumen, and this is probably false lumen. So if you follow my cursor, we can see that this little area here, that's actually the true lumen, which is being squashed by this false lumen, which has some thrombus. So similar to a PE, it's like thrombus, which can fill. There's a little bit of contrast in the false lumen, and that's all compressing. And if you notice, this is actually quite big compared to all the other vessels we've seen before. So not only has this patient dissected, the dissection has caused a weakness in the aorta, and that weakness has caused it to dilate or become aneurysmal. So aneurysmal dilatation is something you can see in dissection. So, and as you can see, it looks very abnormal. This is the true lumen, and we have a false lumen which looks very heterogeneous because it's got thrombus and it's got contrast in it, and we can see there's some branches coming off. Like we said before, you worried about ischemia. Look at this right kidney. It looks like it's enhancing normally. You can see the cortex and the medulla. The cortex is the brighter outer bit. The medulla, you can see these pyramids here. This left kidney looks like it's very sort of dark relative to the right kidney. So this is probably being perfused less compared to the other side. So, and this is just the dissection coming further. So these can go really far down all the way into the pelvis. So that's just an example of a type A dissection. This is a type A dissection with rupture. So rupture is one of the things we don't want to see. It's very bad for the patient. So again, left ventricle, as we come up, we can see the ascending aorta. There's nothing going there. And then as we come here, we've seen a lot of lines. It's very heterogeneous. And for some of you that have noticed, there's this meniscus here. This is a big left pleural effusion. You can probably see that there's a slight difference in the attenuation. So this one here is a lot more dense compared to the one here. So what this is this is actually blood, because blood has the same attenuation compared to soft tissues, things like muscle. So it's very similar. This is probably just some fluid which is reactive to the blood within the pleural space. So this is a left hemothorax. This patient probably around the aorta as well. Here in the anterior mediastinum, again, it looks like soft tissue or muscle. So this is ruptured into the mediastinum. So this is blood within the mediastinum. So again, this is a dissection which is ruptured, which is a bad thing. So very abnormal. So again, we've talked about intimal disruption, false and true lumens. Those are some of the terms we'd use. Stanford types, so A and B. A goes to cardiothoracic surgery. Type B will go to vascular surgery, and I'll explain that in a moment. So we'll talk about this entity called intramural hematoma. So say if there isn't an intimal tear, but underneath this layer on the intima, you can get some hemorrhage, and that's what it can happen spontaneously, and the patient can present to A&E with chest pain which radiates to the back. And what that is just you're having some blood which is forming within the wall of the aorta without any tearing. And this is a lot rarer than dissection, but it's just something that we sometimes see, and it's useful to know. It's part of the acute aortic syndrome. In this non-contrast CT scan, we can see that this patient has this crescent, which looks, this crescent here, which looks like it's a little bit brighter than the inside of the aorta, and that's just blood within the wall. Again, this is very rare. You don't see too many cases of these, but it's part of the acute aortic syndrome. As you can see in this CT scan, there's high density similar to bone where the coronary arteries are. So this patient here actually has quite a lot of coronary artery calcification. So they're at risk of having things like myocardial infarction or acute coronary syndrome. So I'll show you this intramural hematoma, type B dissection, and the left subclavian also has lost its pulse. So the intramural hematoma on this actually is quite difficult to see. If we zoom in here, you can see there's a little bit of a circle here, but it's not as obvious as the previous one. But if we switch to the contrast, you can see that that's where the contrast is going. So this is actually intramural hematoma. and this is the lumen of the aorta. And as we go up towards the arch, the patient hasn't got a pulse in the left arm, and similar to a PE, there's a filling defect. So this is the left subclavian artery, and as we can see, it just goes dark, and we can't see any contrast when you look at the other ones for reference. So this one has contrast. That's the left common carotid, and this doesn't have any. So that's occluded because of this intramural hematoma and dissection. And as we come down, you can see this looks really abnormal. Here we have a dissection. Here we have the true lumen and the false lumen. Like I said, false lumen tends to be bigger. And as we keep coming down, it looks all really abnormal. So here we have false lumen, true lumen, and within the false lumen, you can have thrombus formation. So that's just an example of intramural hematoma, dissection, and occlusion of the left subclavian. This is just a brief slide on another acute aortic syndrome. Again, very rare. You can have this abnormality within the intima, and it looks very rounded, and it goes into intramural hematoma, and it looks like this. So this is obviously the kidney, the left, the right. This is the liver. This is a bit of the spleen, the left lung, the right lung, and we're looking at the aorta here in the coronal plane. And you can see this saccular outpouching into the wall of the hematoma here. You don't have to know what this is, just be aware that this is something on the spectrum of acute aortic syndrome. So I mentioned before, what's the importance of the type A and type B Stanford classification? So with type A dissection, because it can involve structures like the aortic valve, it could rupture into the pericardium. It involves a lot of structures which are managed by cardiothoracic surgery. So if someone mentions a type A dissection, you need to contact and refer to the cardiothoracics. That's what we would do in our center. If you have a type B dissection after that left subclavian artery, then they're managed by vascular surgery in most cases. So you call them, the reason being, I'll just give a few examples. Say if you have a type B dissection, a lot of the time, if you just control the hypertension, a lot of these dissections will settle by themselves and they won't have any harm down the line, and they can resolve. And usually they're safe if you just manage them conservatively. Obviously, if anything happens, you reassess the situation, but that's why they will go to vascular surgery. If you have a dissection, and as you saw, they can become aneurysmal, what you worry is that they become weaker and weaker as they grow bigger and bigger, and they can rupture. So you have to keep a close eye on these patients by monitoring them clinically and also doing some interval scans to make sure that these dissections aren't growing bigger and bigger, and that will vary on institution to institution. And remember, if you have a dissection, think what branches could be compromised and what's going to become ischemic. Any of those branches can become ischemic, so it's good to know your anatomy and to realize what is at stake with dissection. Briefly, with thoracic aortic aneurysms, usually if they're above 4 or 5 centimeters in axial diameter or diameter, they grow weaker and they can rupture, and the patient can become very unwell and die from these. So they're normally picked up incidentally, and depending on where they are, they can either be fixed surgically or endovascularly. I won't touch onto those because that's a big subject, but it's just to be aware. And you have seen a case of dissection and rupture from aneurysm, so you've seen a case of that. So I'm just going to double check if there's any questions. I can't see any. Kev, please do let me know if I've missed any. And we're going to quickly fly through the lungs. So these are the things I want to cover in terms of lungs. So a common thing would be consolidation. It's quite an easy concept. I'll talk about ground glass opacities, which I mentioned before, but didn't have a chance to go into details, but it will be very simple, I assure you. We'll talk about cardiac failure because that's a common cause for breathlessness. We'll briefly touch on emphysema and bronchiectasis. It's hard to cover everything else, things like fibrosis, interstitial lung disease, because those itself are talks by themselves and they're very complex. So I want to get you sort of the most out of acute things that you'd see which are common. So let's talk about different sort of lung abnormalities. A lot of question I get from doctors are, do I need a high resolution scan? You'll be often taught in med school to diagnose things like bronchiectasis, you need a high resolution CT scan or a HRCT. What is a HRCT? What it technically means is that when you scan the patient's chest, you produce thin slices which are thinner than 1.5 millimeters. So if you think historically back in the day when our CT scanners weren't as advanced, you couldn't get such thin slices unless you asked for them and asked to look for things like bronchiectasis. But all our scanners, mostly around the world now, they have updated. So as standard, well, at Addenbrooke's where we'd scan, when you scan the CT chest, you will get thin slices up to 1 millimeters as standard. So if you ask for a CTPA, I'll be able to tell you if the patient has bronchiectasis or fibrosis as well as a PE. So that's just clearing things about HRCT, CTPA. They are essentially CT chests, and if you give contrast, it will be CT chest with contrast. So let's go back to basics now. So let's start talking about consolidation. What is, sorry, just checking. No other questions that I can see. Good. Let's talk about consolidation. So in simple terms, let's think about the alveoli. If you fill the alveoli with fluid, that will produce consolidation. And usually the bronchioles above that are spared. And what could that mean? So a lot of people will talk about consolidation, and as soon as you say that, they'll say, oh, that's infection, that's pneumonia. Technically, it's not, but we use it so frequently that it's become synonymous and people use that term. So if you have pus in the alveoli, you'll get pneumonia. If you have transudative fluid, that can be related to cardiac failure or pulmonary edema. If you've aspirated or if you've got a foreign body, that's going to just go into your alveoli. If you bleed into your lungs and alveoli, that's hemorrhage. You can have sort of autoimmune diseases causing that, such as GBM disease. You can have fat, things you've inhaled, you can have tumor, you can have protein, you can drown, you can have water in there. So anything that fills the alveoli, that can be fluid, is consolidation. And what does that look like? You've probably all seen consolidation on a chest x-ray or chest radiograph, and what it looks like is air bronchogram. So you have an opacity. So as we can see this right lung in this pediatric patient. What you can see, there's an ET tube here, endotracheal tube. We can see that they've got another line, which is probably an NG tube. And here we can see that this area of the right upper zone or right apex is dense, it's high, it's got an opacity on it, and it's got these linear lucencies, which we call air bronchograms, highlighted in red. And once you see air bronchograms, that's the sign of consolidation within an opacity. So that's what you see on an X-ray. And exactly when you do a CT scan, that's what you'll see. You'll see air bronchograms. So you'll see an opacity, which looks dense. So this is a CT scan axial slice in the lung window. Remember, everything else outside the lung looks white, but we've got nice detail. Here within the posterior parts of the right and left lung, we can see dense areas or high attenuation areas with these low attenuation linear air bronchograms. This is bilateral consolidation. So this is a patient with bilateral pneumonia. I mentioned something about ground glass opacities before. What is ground glass? You may have heard of it, but no one's actually really explained. So let's think about consolidation. We know that consolidation is an opacity with an air bronchogram. That is consolidation. That's fluid in the alveoli. When you have ground glass opacity, what you have is, again, an opacity, but it's not as intense. It's quite hazy. And the true definition of ground glass opacity in the lungs is a lung opacity where you can still see the pulmonary vessel running through it. So here you can see the vessel, see the vessel, see the vessel, and you've got an opacity in the background. Here where it's darker, that's probably normal lung, but this is ground glass. Here we can't see any vessels, air bronchogram, consolidation. So that's consolidation, that's ground glass. And people often describe ground glass as being this hazy appearance. Ground glass relates to this technique of making glass and blasting it with sand so that it has this sort of hazy appearance. And that's what you're seeing in the lungs, this hazy appearance of the lungs, but you can still see the pulmonary vessels. So you've learned today that that's what a ground glass opacity is. It's this hazy appearance, but you can see the vessel. So now we got that out of the way, let's talk about different types of consolidation. Consolidation, it can be fluid, so transudative fluid. So this patient's coming quite unwell. You've got this defibrillator pad on this patient. They've got an endotracheal tube here. They've got an NG tube, which is going in towards the lung. And they've got these big opacities within the right lung. And we can see some air bronchograms within some of these areas. It's a little bit of consolidation on the left. So it's bilateral consolidation, worse on the right. If we sort of window, like I mentioned before, brightness and contrast adjustments, you can start to see there's lots of lines going on here. And if you think in the periphery of the lungs, you shouldn't really have lines sort of in the last centimeter edge, but we can see these lines here, and these are what we call the curly B lines, which you've been taught, or septal lines. And I'll explain why that happens. So this is just a CT of the same patient in the coronal plane. We can see that they've got this bilateral sort of consolidation, areas of ground glass as well. It's sort of a spectrum there, but you can see all these little curly B lines on the edges. So we can know that this is probably a patient with cardiac failure and pulmonary edema. And you can see more of these curly B lines. We can see areas of what we saw consolidation and ground glass. Again, it's not going to be one or the other. It can be a combination of both. And this is what cardiac failure looks like. So here, a bit more dense with these air bronchograms. So this is a better example of more consolidation, but areas of ground glass as well. So why does it look like that? Why are we getting all these appearances? Why do we get these curly B lines? No one ever really explained that to me when I was sort of training, until I got into radiology. So if we just think about when you get right down deep into the lung, down to the last level, you end up getting a bronchus, which is this slightly pinkish vessel here. You've got the artery, which goes into what we call this second pulmonary lobule, this hexagon shape, the second pulmonary lobule, and you have lots of sort of air structures within these. So what I want you to focus on is around that is you have the veins. So the blood and the air goes in, and then it goes to the edges, and it returns by these blue veins. So these are the pulmonary veins and lymphatics. And these are between the lobules. So these are interlobular septa. So just remember that the veins go on the outside of these lobules in the interlobular septa. And that's exactly what you're seeing with curly B lines. So if you have a look, you can start to see these second pulmonary lobules. So you can see these sort of hexagons or polygons. So if I draw the polygons, there's probably one there. There's probably a few here. There's probably another one there. So if I go back, so you can see what I'm talking about. It's very subtle, but they are there. And those are those veins that have been distended because of cardiac failure. The heart's not pumping it, so it's all just backlogged in these veins. And that's what's happening. You're getting these second pulmonary lobules. They're just being filled, and that's why you get all these lines and curly B lines. And contrast that to normal lung. So that's an explanation as to why you get curly B lines. That's what's happening at a level. You're getting these veins distended. So some more cases of consolidation and ground glass. Hemoptysis. So this patient was coughing up blood. How do I know that this is probably hemorrhage within the lung? It's because the clinician has told me they're coughing up blood. They've got an autoimmune disease, and this would be consistent with that. It's sometimes hard to tell the difference between infection or blood. It's all about the clinical context as well. These are patients who have aspirated, so all these things have gone into the lungs, and it looks like consolidation, nice air bronchograms. Here we have a more subtle case. This is probably more ground glass, but it's more in an area on the right side of the lung where the patient would aspirate. Here we have lots of nodules, so rounded areas, less so consolidation, but this is the case of aspiration. You get lots of nodules. Here we can start to see these polygons, these interlobular septal thickening. So these could be areas of edema. So you can get overlap between those of different things. Consolidation is important in tumor. If you think this patient could just have an infection, but this could also just be a lung cancer. And that's the scary thing when it comes to consolidation on chest x-rays and CTs. And the important thing is that we recommend following these up. So normally after at least 6 weeks, after you've given them some antibiotics, you want to rescan them. So if they've had a chest x-ray, You give them some antibiotics, they'll have a repeat one. If it's all gone, that's great. If it's still there, you may not have given the right antibiotics, and it might just be another infection, but you'd start to suspect they may be having a tumor rather than just an infection there. Obviously, you can have both, but it's important to follow up these patients. Quickly talk about emphysema. We're nearly at the end, so we're just on the home stretch. So emphysema, so obviously lots of smokers, you get damage to the distal sort of alveolar airway spaces, and those become dilated and they can't exchange as well. There are different types of emphysema, but essentially it just makes the lung look a lot blacker. And these are the, sorry, I've just got a question here. So I've got a question from Anna. How soon do we need to order CT or X-ray if we suspect aspiration? Is X-ray enough, and how much time between ingestion and imaging? I would probably say if you suspect a patient is unwell and they've got chest symptoms and you think they've aspirated, it's worth doing a chest X-ray. It really depends on how urgent you want to get it. Having the X-ray will help you see the aspiration or consolidation and will help your management. So we wouldn't recommend any time limit. I think it's whenever you want to get a chest X-ray, get a chest X-ray. You probably don't need the CT as a first line investigation for aspiration. A chest X-ray will do. I think if patients are aspirated and then say in 3 or 4 days or in the future they become more unwell and you think you're not really winning with your treatment, it's worth doing another chest X-ray because they could have gotten worse. The consolidation may have gotten a bit bigger. They might have a pleural effusion, stuff like that. So I think chest X-ray is good to start. I hope that answers your question. Oh, I think how soon will the findings appear on X-ray for aspiration? I don't think there's a rule that we normally see for in terms of X-rays. It's not something we think about. It's normally if they have an aspiration, in my institution at least, they would get an X-ray, and I normally see it sort of on the same day. I know a lot of the aspiration cases I've seen, I'm diagnosing it on the same day, normally sort of within sort of 6-7 hours. So I think if I've seen cases that early, I would just get a chest X-ray just to try and get a diagnosis. You can delay it if you think it's going to increase a bit more, but in my experience, I've seen aspiration as early as within 1 day. So we're going to talk about emphysema, so common in smokers. There are different types. A lot of the time you will see things like central lobular emphysema. So now that I explained the concepts of that pulmonary lobule, remember that hexagon, that polygon shape, that's essentially what we're basing off emphysema. So centrilobular is obviously going to be in the center of that lobule. Panlobular is all of the lobule. Paraseptal is next to the septa, so close to the edges of that lobule. So now that you've learned some anatomy, you can sort of know about cardiac failure and emphysema. So centrilobular, if you think about all the CTPAs I show you where there was normal lung tissue, sorry, I'm just having a look at some of the questions. I'll explain these and then I'll go through onto there. So we will, if you look at the, so this is an axial lung window of a CT chest. We can see that there's lots of black spaces. So normal lung tissue is probably around here. It's a little bit gray and you have these darker circles, and this is centrilobular emphysema. And this is common in smokers. It usually tends to affect the apices. If you think smokers, whenever they smoke, inhale, a lot of the smoke tends to go sort of to the apices, so that's where it sort of predominates. You can have panlobular, where it's a lot more extensive. Again, I appreciate if you haven't seen many CTs, this might just look similar to the other ones. Normally affecting the bases, you can have things such as alpha-1 antitrypsin deficiency, where you can have this panlobular emphysema in young patients at the bases, and they tend to get problems with their liver as well, so things like liver cirrhosis. So paraseptal, you can get them in smokers and young adults, and it looks like it's more on the edges, so that can cause a pneumothorax if any of these blebs or bulla pops. So a bleb is just something which is like this but less than a centimeter, and a bulla is above centimeter. Bronchiectasis, irreversible, sorry, I'm just going to stop to answer some questions about aspiration. So there's some questions about children who have ingested. So I came across a patient of a 9-year-old kid who ingested a peanut, almond. Radiograph is normal and CT was advised. So I apologize. When I was talking about aspiration, I was thinking about aspiration of sort of gastric contents. A lot of the time, that's what we see. In cases where it's a foreign body and you're worried that it's lodged within an airway and you can't see on a chest X-ray, you can use a CT to see exactly where the location is. Of course, a CT is going to give you a lot of better anatomy to locate exactly where it is and sort of guide any of the endoscopists as to where they can go and try and get the foreign body out. So yes, you can do a CT. It really depends on the clinical context. If someone's swallowed a foreign body that they can get out manually, obviously a CT will be very helpful if you can't see on the chest X-ray. But in most of the cases that I see in hospital, these are going to be patients who, say, have had strokes, have been unconscious, and they've aspirated a bit of food or gastric contents into their right lung. So that's what I was talking about before. I apologize for that. How useful is CT in rarely elucent ingested foreign particles, peanut, almond, in a patient with signs of breathlessness? So again, yeah, CT is very useful because it will help you find where the foreign body is. So I hope that answers your question. So we're going to talk about bronchiectasis. So bronchiectasis is irreversible airway dilatation due to chronic inflammation or repeated infection. So patients, say, with cystic fibrosis, they will get bronchiectasis. There are different types. So this is a normal airway. You can have cylindrical, where it's all sort of smooth, varicose, like the veins, when you get varicose veins, and cystics, where you have these sort of ball, cystic-like appearances. You don't really need to know about this. All you need to know is that you get irreversible airway dilatation. And the sign that you classically get taught in EMQs and things like that is this signet ring sign. So what we have here is axial CT slices of the lung. We can see that here we have a bronchiole here, and we can have the adjacent pulmonary vessel. And the pulmonary vessel here is a lot smaller compared to the airway. And whenever that happens, that's the signet ring sign. So it's the pulmonary vessel is smaller than the adjacent airway. You have to be careful because sometimes if someone comes in with normal healthy lungs and they get a chest infection, sometimes their airways, just as a reaction, can get a bit bigger. So sometimes you might just have to put it down to an infection rather than true bronchiectasis. So sometimes we don't like to label patients too early, especially if they've just had a CT chest and it's just an infection and a one-off. But when you talk about bronchiectasis, signet ring sign is usually what you are looking at. Here we can see some more cases of signet ring sign. So here's a nice case. The airway is bigger than this pulmonary vessel. Here, this pulmonary vessel is probably sort of similar size, but we can see that the lines around the airways are a little bit thickened. So it should normally look something like this, but some of them are looking a little bit thicker than they should do. And that's just that inflammation and thickening of the airways from the chronic inflammation. So that's another sign you will see. We'll talk about pleural effusions, pneumothorax, and some other things. So essentially in the pleura, you're thinking about these entities. So here's an axial CT slice through the lungs. We can see that you can see these big menisci here. So we've got lung and soft tissue windows. These are big pleural effusions. Well, these are sort of small to moderate size pleural effusions on the right. On the left, this is probably a small one. If some of you have noticed, the lungs look a bit ground glassy. You can start to see a few polygons, hexagons, lobules. So this is a patient who has cardiac failure and bilateral pleural effusions. If we draw a region of interest, we can measure pleural fluid, and anything between -10 and +20, that is simple fluid. So this is just sort of transudate from the cardiac failure, causing these pleural effusions. So again, we can measure fluid to prove that it is close to 0 on the Hounsfield unit scale. Empyema, that relates to infection, so infected fluid within a pre-existing body cavity. So it's not just the pleural space, which is what we're talking about today. It can be in other places like the subdural space, the gallbladder, a synovial joint. And normally we give contrast to show the enhancement of the pleura because it's inflamed and infected. So the thing that we get taught in radiology is this sign. So we can see that the pleura is enhancing. So there's a visceral and there's a parietal pleura. So the parietal is the one closest to the chest wall. and we can see some fluid there. So this is abnormal enhancement. We see contrast within the aorta here. So this pleura is enhancing because it's inflamed from the infection, and this is called a split pleura sign in radiology, and that's just a sign of empyema. Empyema is not as common as your pleural effusions, but they are very serious diagnoses. Here is one. You can't really see the split pleura sign too well compared to the other side. It's probably around here, but what you can see is this sort of ball of pus. It looks like it's fluid attenuation. It looks very similar to almost like muscle, probably because it's got some contents making it look a bit more dense, probably some pus, some other fluid, some bacteria, and it's got gas locules here because the bacteria are producing gas. So this looks like quite a big empyema. Here we have a nice empyema on the left with that split pleura sign that we were mentioning before. This is an infected fluid collection. And this is just another one. We can see it's quite large on the left side. This is a left empyema. I've just got a question about, so I'll finish this bit. Empyema and ultrasound. So when you can do an ultrasound of empyema, what you're looking for is, so in any ultrasound, fluid is black. So an ultrasound fluid, if it's simple, if you were to scan a bottle of water, it would look black, and that's what it looks like. Here we can see pockets of black, and these are areas of fluid, but you can see all these webs. It looks like a spider web, and all these webs are because of infection. You have these webs, or what we call loculations, and it's going to be really hard to drain all of this because of all these sort of areas of fibrin and all these areas of pus. So this is what an empyema will look like. So here we have the pleural space. Here we have the diaphragm and the liver. So this is the right side of the lung, and this is what it looks like in ultrasound. I have a question from Rajan saying, what does ground glass nodules indicate? Malignancy, infection. So like with anything in medicine or radiology, an appearance can mean several things, and there's a long list of ground glass. There is a very long list, and that's a talk on itself. It can mean aspiration, it can mean infection, it can mean heart failure, it can mean malignancy. And that's what radiology training will sort of teach you as you see more and more. It depends on where it is anatomically, the context, any other features. So if this patient has lots of pulmonary metastasis, bone metastases, lymph nodes, and they've got ground glass nodules, it could be that these are malignant. If a patient has come in unconscious, but they've got no signs of malignancy on their chest, they've got lots of right lower lobe, right middle lobe, nodules and ground glass, they could have just aspirated. So it really depends on what you're looking at, the context, and knowing the long list of differentials, which is quite difficult to go through all of those, but I hope that sort of answers your question. Pneumothorax. So this is a chest x-ray, which is very abnormal, one. There is a pneumothorax on here. On the left, so this is where the pneumothorax is. You can see that sharp line there, but the other abnormality is that there's lots of dark linear lucencies throughout the chest wall. So this is surgical or subcutaneous emphysema, and this is what it looks like on the CT scan. So here we can see a normal right lung. You can't really see the right pleural space because it's normal, but here what we have gas within the left pleural space, and this is that pneumothorax from the same patient. And what's happened is that they've also got lots of air within the soft tissues, which is called surgical or subcutaneous emphysema. And when you examine this patient and push on their chest or their back, you'll get that crackling sound. And here's just a chest drain within the left pleural space, which they're trying to drain that pneumothorax. I'll just finish this section and I'll answer the two questions that are on there. So hydropneumothorax and pneumothorax. Hydro just means that there is fluid. So if there's a pleural effusion and a pneumothorax, like here, on the right side, we've got a nice fluid level, and we've got a pneumothorax here. So add those two together, that's a hydropneumothorax. It's just a technical term, and that's what it looks like on a CT scan. So you can see a nice fluid level, air, the two together, hydropneumothorax. And pericardial effusion, obviously fluid attenuation surrounding the heart, that's a pericardial effusion. Normally you have about 10 to 15 mils, 50 mils within there. Anything above that, it starts to accumulate, has mass effect, impairs the ability of the heart to pump, and there's lots of causes which you can go into your books. It can be infective, malignant after an ACS, and normally echocardiography is the best modality. So just going to answer some questions. So I've got a question: in the case of consolidation, if there is a proximal focal bronchus cutoff sign but intraconsolidation bronchograms are visible, does bronchus cutoff sign always favor malignancy? So yes, so that's an important point. So like I mentioned before, with consolidation, if you, let's get back to there. Let's take this example. So say if suddenly this bronchus is cut off and everything downstream has consolidation, or it's collapsed, that would be worrying for malignancy. Usually if you have consolidation, you can see the bronchograms and you can analyze the airways. What happens whenever you have a cutoff sign, you'll have collapse, which I haven't covered on this just for time reasons. If you collapse a lobe, you can't get any air through to aerate, so you lose volume and you won't see these sort of air bronchograms all the time. And that's when you have to worry. Whenever you have lobar collapse, you always worry, is there underlying malignancy? Yes, a cutoff sign in consolidation, that could be worrying for malignancy, but it could just be that there is mucus or debris within the bronchus at that point. So it's really hard to tell, and that's why we recommend the follow-up imaging. How to differentiate between intramural hematoma and aortic dissection on axial aortic view. So let's go. So intramural hematoma, you need a unenhanced CT scan. So to diagnose intramural hematoma, you need an unenhanced scan just to show you this. But again, like I said, these acute aortic syndromes, there's a spectrum. You can have intramural hematoma, and down the aorta, you can have a dissection, and that dissection can cause an aneurysm, and that can rupture. So the patients don't always have to just have one or the other. They might have a range of things. So you can have dissection with intramural hematoma. It's just sort of descriptors that we use. About how to differentiate them, what you need to do is to make sure that whenever you look at intramural hematoma, you can't see any false lumen. So for dissection, you need true and false lumen, and that sort of dissection flap, like we said before. So if we go back to our here, we can see that there's two different lumens. Intramural hematoma, you wouldn't have the two lumens. You'll have one true lumen, and you'll just have dense crescent going along the side of the wall. So hopefully that answers. So I'm aware we're sort of 10 minutes over. I'm going to just quickly go through my last few slides, which is trauma, which should hopefully not take too long. So leave a few more slides. So this is a patient who has come in as a trauma. We can see that there's an endotracheal tube. This is within the trachea. They've got an NG tube here. So they're quite unwell. They've been intubated. We can see this is the right clavicle, and you can see that there's a fracture here. So high impact. And we're just going to go through some of the slides. So we're just going to put together some of the things you've learned today. So as we go through these lung window slides, you can see that already the right lung and the left lung are really abnormal. You can barely see any normal right lung. You can start to see some bronchograms actually within this right lung. So this patient is probably filled up with either aspiration or there's hemorrhage within the alveoli. So these are contusions in the setting of trauma. You've got some areas of ground glass here as well. So again, this is the left side. They've probably hit the left side of their chest. So again, these are contusions as well. So contusions can be ground glass, they can be consolidation. And here, if you imagine this patient has hit the front of their chest, these bits of lung have probably compressed and bled into them and had these contusions. And again, we've got contusions which manifest as consolidation and ground glass in these areas. So in the setting of trauma. Here we have laceration. So if you think a contusion in the lung is basically like a contusion in the skin. It's like a bruise. So like any of you have had a bruise, you just get a bit of bleeding within the tissue. If I were to lacerate my arm, I would be doing a cut, I'd be tearing it, and that's similar in the lung. As you can see here, this is normal lung tissue. Here you can see these sort of circular cystic areas with gas within them, low attenuation. This is areas where the lungs have been torn. These are what we would call traumatic pneumatoceles. I'll spell that. Sorry, I didn't put that in there. So these are basically tears within the lungs. So you can get contusions, you can get lacerations, and that's just from force or blunt trauma. Here you can see within the mediastinum there's lots of gas. So this is what we call pneumomediastinum. You can see gas going around the aorta, which we didn't see before. Gas around the trachea, gas outlining this structure, which is the esophagus. So they've got pneumomediastinum and they've got some lacerations. We'll talk about flail segments. So what that means, the strict definition is that you have 3 levels of ribs where these are contiguous, so they're one after the other, and they've got 2 areas where they're broken. So this will be a flail segment. And what does that mean? Usually it means there's enough trauma in this area that the underlying tissues have been damaged. So this, I think, is my last example. So this is the axial soft tissue window. So if we start from the bottom, we can start to see there's a bit of gas which is outside of the ribs, which is not good. We can see the ribs aren't sort of following each other, they're sort of jumping and jumping. You can see they're all over the place. So this patient has multiple right-sided rib fractures, and this is probably a flail segment if you were to count it. We can see that there probably is some consolidation. There's consolidation, which probably relates to contusions, like we mentioned before. We can see these cystic spaces here, which these are the lacerations. If we go back to, we've got some areas of sort of ground glass nodules here. These probably relate to contusion as well, but they could be areas of aspiration depending on the position of the patient. What else do they have? If we go back to the lung window, we can see there probably is a little bit of a meniscus underneath the lung, maybe around here. So that could be a hemothorax or maybe a pleural effusion. It's probably a hemothorax in the setting of trauma. So those are the certain things that you can see: contusions, lacerations, hemothorax, pleural effusion, and rib fractures and flail segments. So I've just got another question. Is the enhancement of consolidation seen in benign conditions? So whenever you see consolidation in the lung, let's just get one. It's really hard to say whether or not there is enhancement in this area of lung. It's so dense that you can't really see any as areas of enhancement. It's actually really difficult because everything's squashed together. So whenever radiologists are looking at it, we don't really say, oh, there's an area of consolidation which is enhancing. Normally, if you saw an area of enhancement, it would look like a lesion. So it'd look like a rounded shape or an abnormal oval shape, which when you scroll through it, is basically looking like a ball within an abnormal area. It probably would push some of the vessels away, and that would tell you that there's probably a mass somewhere there. But it can be very difficult, and that's why we often say repeat the scan, because there could be small cancers hidden in consolidation, but a lot of the time it's really difficult to sort of identify that. If you imagine, can you spot a small lung cancer within all of this? It's near enough impossible. So you would have to advise you get repeat imaging. In this patient who's probably young in a car accident, they're probably not going to have a cancer. I can't see any other signs of malignancy elsewhere. This is all related to trauma in the clinical context. So this patient probably won't need a follow-up scan, because this is confident you can say this is most likely all related to trauma. But enhancement, we don't tend to talk about enhancement with consolidation, but you can see enhancement in lung nodules, which can relate to malignancy, but a whole other host of things. So radiology gives you a lot of differentials, and it's sort of trying to identify all the things. So just closing up, the whole idea of today was to gain some confidence looking at some CT chest studies, see normal chest anatomy, see some common pathology, and maybe some uncommon ones, which I've mentioned. I wanted you to learn some basics, so hopefully you've learned some basics from chest x-rays now translated to CT chest. And you've asked a few questions for me, and I'm happy for you to ask some more. So hopefully you've finished today learning something new. I've used Radiopedia, as you see, extensively. It's a great resource for anyone wanting to learn. It's what I used during med school to try and spark my sort of learning with radiology, and it's a great resource to just look at anything. And that's just one of the radiology books I used. So thank you for listening, and I'm happy to take any other questions. Someone's want to go to the first slide to show all the topics. So this will be recorded. There we go. So I think Kev might be there. Let's have a look.
Yes, thanks, Dexter. That was amazing. You taught us loads this evening, or I've certainly learnt loads. I'm sure our audience will agree that all the cases were really helpful for their learning. I remember when I was an F1, F2, and I had no idea what I was looking at when I was looking at CT scans. But hopefully after tonight, our audience will be empowered to look at CT scans when they've requested them and have an idea of what they're looking at and spots of pathology. This is the last session in this radiology series. This is recorded as well as all the other ones that we've done, and you can watch them on the Mind the Bleep website or on the Mind the Bleep YouTube channel. There's about 15 to 20 hours of really good content from this series that you can go through, and the way that we've structured it, it should cover everything that you'll need to know as a non-radiologist doctor. You should all get feedback links emailed through to you. Actually, let me just send them right now. So they should have all just gone to your emails that you signed up for. If it hasn't gone through yet, then it should arrive in the next few minutes, or certainly within the next 10 minutes. But I will also paste the relevant links into the chat box in a second. And then once you fill in the feedback, you should get an email sent, a certificate sent to your email. So there is a couple of questions here. Can you do one an abdo CT or even a brain CT? So we've done those already. So the abdo pelvis CT was last week, and the CT head was a couple of months ago actually, but they'll all be uploaded onto Medal, onto Mind the Bleep, on the website, and also onto YouTube. So they're all very similar structures to this one. Are there any other questions that we have? I'll give you a couple minutes to ask any last minute questions just while I post the relevant links into the chat box. Give me a second to do that. So that first link should take you to directly through to the feedback link where you can fill in feedback for this session, and then you'll get your certificate after that. The second link is going to take you to how to sign up to all the Mind the Bleep webinars that we have. So there's quite a lot going on at the moment. There are medical webinars, surgical ones, ophthalmology, pediatric, urology, finances. I'm sure I'm missing some, but there's loads going on at the moment. So if you follow that second link, you'll be able to register and sign up to all the ones that are happening. And if you go onto the Mind the Bleep website, I'll make sure there's the page set up so you can reach all the webinars that we've done for the radiology series in one place, and I'll make it really easy for that to happen. So we'll give it another minute just in case there are any questions that flood in, because sometimes they come in last minute, and if not, then we'll wrap up, I think. So thanks again for that, Dexter. That was really, really helpful.
Do you have any questions, Kev?
Well, people have already asked the ones that I've had, and you've explained pretty much everything that I'd want to know. Lots of terminology that I think you can go through med school and your F1, F2 not really knowing exactly what they mean. Things like, you know, what do curly B lines, what are they? What do they actually look like? And I think you've explained it all really well, especially, you know, why do they appear? There's lots of things I think we just accept in medicine that it's just there, but it's very useful to know how they actually come about. If that makes sense. So it looks like there aren't any more questions. So thanks again, Dexter. Thanks for everyone who's been keeping up with this series over the last 3 months. It's been really fun to make this for everyone. And thanks again to all our presenters, and thanks again, Dexter.
Of course.
All right then. Take care, everyone. Thank you.